disaster. For that, today we have got Dr. Supriya Arwari with us to share her experience. Good evening, madam, and welcome to this webinar.
Good evening, sir.
Dr.
And
Supriya Arwari is MD, DGO, FC, PhD, MD. Madam is practicing in BUND since 22 years, consulting obstetrician, gynecologist, and infertility specialist at Supreme
hello.
Hospital, BUND. Hello.
Yeah.
Yes, madam. Chairperson AMOGS Adolescent Health Committee, Chairperson TOGS Adolescent Health Committee, Managing Committee Member Association of Medical Consultants of Mumbai. Dr. Arwari is past president IME Bhiwandi and Bhiwandi Medical Practitioners Association, recipient of Dr. Anandibai Doshi Award for Meritorious Services by Female Doctor for Bhiwandi Nizampura Municipal Corporation, winner of the title Mrs. Iron Lady in Beauty Queen and Mrs. Maharashtra Beauty Pageant 2020, first of its kind in women doctor. Madam, welcome once again for your sharing your experience.
Thank you. Can we go to the slides? Yes.
Yes, madam.
Yes, sir. So basically, we are going to talk about postpartum hemorrhage and about Carbetocin as a drug of choice in postpartum hemorrhage. PPH, as we all know, is a very frightening complication of delivery that any obstetrician's nightmare. It is basically defined as at least 500 ml of blood loss after vaginal delivery and 1000 ml of blood loss after a cesarean delivery. It is very commonly it can occur in women who are at high risk, but also can occur in women who are actually speaking low risk or do not have any risk factors. And it is overall causes nearly quarter of maternal deaths globally. So this is a very frightening figure. Unfortunately, it is still common because one of the leading cause of leading cause of maternal mortality. More than 30 to 40% women dying in the postpartum or in the peripartum period die of PPH. In the developing countries, the MMR is very high, still 240 per 1000 live births compared to only 16 in the developed countries. Fortunately for us in India and especially in Maharashtra, we are all have been working very hard and trying to bring this maternal mortality figure to under 100. 14 million women suffer from PPH and incidence is reported to be 2 to 4% after vaginal birth and 6% after cesarean birth. And 38% of maternal deaths already I have mentioned that around 1/3 to 1/4 women of usually die due to PPH. The global deaths take place in India around 25%. So 1/4 of the global deaths which occur due to PPH take place in India. This is a very sad state of affairs, and unexpectedly high maternal mortality is faced by Indian population. Common causes, we know common causes of postpartum hemorrhage are the 4 T's, that is the tone, thrombin, trauma, and tissue. By tone, we mean uterine atony, that the uterus is unable to contract, and therefore what the uterine musculature usually acts like a living ligature for open sinuses in the uterine cavity, and therefore the natural mechanism helps in preventing PPH. But when the tone is bad, when the atony takes place, that is one of the commonest cause of postpartum hemorrhage. Thrombin, whereby we mean coagulopathies or failure of coagulation due to any risk factors. Trauma, that means any of the injuries to the birth canal. It can be vaginal tears, it can be vulval hematomas, it can be cervical tears, and sometimes even uterine tears. And by tissue, we mean retention of the products of conception, that is either the placenta or the membranes or clots, due to which bleeding takes place. Next, please. Now, what are the clinical signs in PPH? First and foremost, we should all remember that technically the definition says 500 ml and 1000 ml. But how will we find out whether this patient, we don't have measuring jars in the labor ward. How will we know that this patient is going to have a problem? So by definition, any blood loss which has the potential or has already deranged the stability of the general condition of the patient, that PPH is something that we should be careful about. What are the findings that we will get in PPH? Usually there will be abdominal tenderness, the uterus will be, say, flabby, soft. The patient may have collapsed already if the PPH has been very dramatic or has been very prolonged. Then peripheral vasculature collapse, increase in abdominal girth, uterine contractions are absent. Maternal tachycardia, hypotension, hyperventilation may be present, and vaginal bleeding will be present in majority of the cases. Next, please. How will we diagnose? Initial evaluation? Quickly, we need to assess the status of the patient at a pulse, BP, whether the vital signs are stable or they are already deranged. There may be, like I said, presence of tachycardia or hypotension, but some patient may have hypertension, which is actually leading to the PPH. So these are the, and we also will look at the whether the uterus is contracted, whether there is any active vaginal bleeding. The genital tract should be, less examined for lacerations, hematomas, or if there is any sign of uterine rupture. Bimanual uterine examination, number one, to see the tone, number two, to see whether there are any retained products of placenta or tissue, retained products of conception, and bedside ultrasound, if available, should be done if the uterus is not contracted. Evaluation of uterus to check for uterine inversion. Now, this is one, luckily nowadays it is one of the uncommon complications, but all the same, we need to look out for that. Lab investigation wise, a complete blood count, hemoglobin, hematocrit, platelets, if the coagulation studies, these need to be seen. Next, please. Now, how will we approach a case of postpartum hemorrhage? Now, we have to first find out which of the T's is causing the hemorrhage, and that is how we will then approach to treating that patient. Now, if that patient is due to poor uterine tone, then there will be a host of uterotonic agents that we would like to give her, including, of course, bimanual massage, nasal oxygen. If it is a tear or a trauma, then in that case, suturing of the tear or packing of the cervix, or exploratory laparotomy if there is a suspected uterine rupture. These are the management modalities that we will accept. In case of retained tissue, if the T is for tissue, that is retained products, then we will expedite removal of the placenta, membranes, or whatever is remaining. If possible, then we will do it under general anesthesia or under regional anesthesia. We do a check curettage to see if we can remove the products. We have to be very careful though if there is some suspicion of adherent placenta. In case of coagulopathy, basically we need to find out the cause of the coagulopathy, treat the cause, as well as replenish the coagulation factors, give her packed cells. If HB is low, give her fresh frozen plasma, platelets, as is the requirement. Attempt should be made to identify the cause, and first, of course, will be the primary assessment. Next. Now, what is the rationale for developing carbetocin in a heat stable formulation? Initially, when carbetocin was launched, it had to be presented maintaining the cold chain. But as you know, in our country, with lot of humidity and heat, maintaining the cold chain is not always easy. So, and most of the oxytocin or ergot alkaloids usually need refrigeration to avoid degradation. Stable formulation of oxytocin is not currently available, and previous even the carbetocin formulations had to be refrigerated. In a poor resource country where either refrigeration is not available, or even if available, electricity fluctuations are there, stability of the electrical connection cannot be confirmed. So in these cases, it is very difficult to maintain a cold chain, and therefore it makes sense if we have a heat stable molecule which does not need cold chain to be maintained. Next, please. Uterotonic agents, of course, will be the mainstay if the PPH is because of uterine atony. Now, when are as a prevention, when can we administer the uterotonic agents? At the time of crowning of the baby, we can give it after the delivery of the anterior shoulder of the baby. We can give it at the end of the second stage of labor. That means after the baby is completely delivered or following the delivery of the placenta. So various molecules will be given at various times during the labor event. Prophylactically, we give it to prevent PPH or as a part of active management of third stage of labor, and also can be given as a therapeutic use when actual PPH has already set in. What are the drugs available? Oxytocin, of course, is the time tested, and since donkey's years we all have been using it. Next in the line is carbetocin, which is now a better choice to oxytocin. Ergometrin, that is what we normally give as methergine. Symptometrin, that is a combination of ergometrin with oxytocin, and misoprostol. We use prostaglandins which are also good in use, but of course, the injectable prostaglandins have a lot of side effects. Next. The third generation drug for PPH management, that is carbetocin. It is synthetic long-acting analog of oxytocin and therapeutically used in prevention of postpartum hemorrhage, especially due to uterine atony. One vial contains 100 microgram of carbetocin in 1 ml of solution for injection. The advantage is that it has a bigger half-life, the degradation is reduced, and therefore ease of use, ease of storage. Next slide, please. And of course, lesser side effects. What are the clinical trials that we have? Lots of trials have been presented in this PPT, which the hetero team has prepared. And the objective was to compare the effectiveness of and safety of investigational heat-stable carbetocin as compared to oxytocin. And in the primary outcome, the proportion of women with blood loss at least 500 ml or less, with blood loss at least 500 ml were used, and they had to be given additionally uterotonic agents. And proportion of women with blood loss at least 1000 ml. These patients were enrolled in this trial. Next. Frequency of blood loss at least 500 ml or the use of additional uterotonic agent with carbetocin was proven to be non-inferior versus oxytocin, and use of additional uterotonic agent interventions to stop bleeding and adverse effect did not differ significantly between the two groups. So this essentially means carbetocin is not inferior to oxytocin for prevention of blood loss of at least 500 ml or the use of additional uterotonic agent. So it can be safely used with other uterotonic agents. Next slide. The Cochrane review states that for women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal delivery, and is associated with significantly fewer side effects. Next. Now, what are the recommendations? There are certain guidelines that can be mentioned by WHO and other organizations. Let us first go with the WHO and FIGO. That is the main guidelines that we normally follow. So only one of the following to be used, that is oxytocin, carbetocin, misoprostol, ergometrin, oxytocin, and ergometrin fixed dose combination. According to FIGO, carbetocin is one of the recommendations for PPH management. As you can see, most of the organizations are recommending carbetocin as for use in atonic uterine atony and PPH consequent to it. Next slide. Next. Yeah. So basically, I have personally used, yes, and I will come to my experience when we talk about the panel question. Definitely, it is a smarter, superior, and safer choice in PPH management. Next, please. Yes, I think that brings me to the end of the presentation. Now, maybe we can go to the discussion as far as our clinical experience is concerned.
Your
Yes, Dr.
experience,
Prashant.
your experience of using carbetocin.
See, I am basically using it in all the LSCS cases.
Okay.
That is already mentioned in your description, in your slides also. The reason I personally feel is that most of the patients of LSCS, if it is elective, they are not on any oxytocin drip. Even if it is an emergency cesarean, where previously that lady has been on an oxytocin drip, by the time the decision for LSCS is taken, the drip is discontinued, and therefore, a carbetocin used after delivery of the baby will give the best effect.
Correct.
Basically, oxytocin and carbetocin are belonging to the same family, and they act on the same receptors. This is an important consideration.
Correct.
That if she's already on oxytocin drip, then the oxytocin receptors will be fully, completely overwhelmed by oxytocin, and therefore carbetocin will not act as good as we would expect it to act. And therefore, patient with pitocin may not get as much benefit as women who are either not on the drip or the drip has been discontinued for 20 minutes or more.
Wonderful, madam. And you said generally for, and what is the mode of use is IV?
IV.
IV.
Either we give it as a bolus or even can be given if
Drip
the staff is giving, always it makes sense
to
if they dilute it and give it.
Correct.
If
And
the
you have,
anesthetist is at the head and to monitor the patient, then can be also given as a bolus.
and you have been using for past 2-3 years.
Yes, yes, yes. Exclusively all cesareans nowadays we use carbetocin.
Any untoward effect you have seen during this?
Not at all, not really. With methergine, we used to see so many things, but with
Hypertension, yes.
carbetocin, I haven't seen much.
Which patient profile can you feel, although in our science it is expect the unexpected, any patient seemingly,
Yeah.
safe and suddenly go, but where we can expect PPH?
They all the women who have some of the or the other antenatal complications.
Okay.
They can be obstetric complication like multiple pregnancies. They can be diabetes, means medical complication like diabetes, hypertension, thyroid in pregnancy. Then it can be polyhydramnios, grand multipara, elderly primies. So these are the women who will usually have, and especially those with PIH. PIH is one of the biggest predisposing factors. Also, women who have antenatal bleeding will have more postnatal bleeding. That is the rule of the thumb. So anybody who has antepartum hemorrhage, either placenta previa or abruption, is more likely to have PPH.
Basically, uterine atony could be one of the causes there.
Yes.
When would you prefer carbetocin or oxytocin for prevention of PPH?
Like I mentioned, any woman who is not on oxytocin drip, carbetocin will be my drug of choice.
And any patient who is at a risk will always prefer carbetocin.
Yes, especially women who are more likely to have PPH, like we have already spoken about these. This is the group of women in which we would be very wary. Also, severe anemic patient. We don't want them to have any more PPH because that will worsen their condition. So definitely we will prefer carbetocin.
In anemia, even a little amount of blood loss could
Already they are, in hyperdynamic circulation, and even little blood loss can push them over the brink.
Can we use carbetocin in case of a retained placenta?
Yes, because in case of retained placenta, now carbetocin has action similar to oxytocin. So basically, it will cause contraction of the upper segment and relaxation of the lower segment and the cervix. As against methergine, which causes contraction of the upper as well as the lower segment. So it may cause prematurely closure of the os. But in case of carbetocin, that is not the case. So definitely we can use it.
And Rh negative mothers?
Yes, because as against methergine, the like I said, contraction of the upper segment, relaxation of the lower segment. And since it has action very similar to oxytocin, the pushing back of the maternal blood into the the fetal blood into the maternal circulation will not be as high as it can be with methergine.
And in the periphery, if an Rh negative mother gets a PPH, getting blood could another be an issue.
Yes,
transfusion.
That is true. Getting blood, and always it is easier to manage Rh isoimmunization at a later date and first save the patient or the mother when she's having PPH. We cannot not give her drugs because she can have Rh isoimmunization and expose her to a mortality.
It could lead to
So always we have to remember this. Rh isoimmunization is always secondary. Primarily, it is to stop the bleeding. That is most important.
Can a doctor use carbetocin for prevention if oxytocin is used for induction?
In that case, oxytocin drip needs to be stopped. The biggest advantage that oxytocin scores over carbetocin is that it has a very short half-life. So within 20 minutes, the oxytocin is usually washed out of the system. So you stop the oxytocin drip, and after 20 minutes, usually what happens is that by the time the patient delivers, that much time is gone. So you stop the oxytocin drip, let the patient deliver, and then by then 20 minutes have passed, we can definitely
carbetocin will work.
If it is the other way around, if we have given carbetocin to a patient and we want to supplement with an oxytocin drip, then give it 45 minutes after the dose of carbetocin.
For a longer half-life.
Yeah, because the half-life is longer.
Is there any place for IM route?
Except I think in the periphery situation where IV line is not secured,
Correct.
and or there is only non-trained staff is available,
Right.
then maybe IM route may be given. Otherwise, I personally really have no idea why I would have given IM. If you have any suggestion, do tell us.
I mean, if the drug, you have to use a drug, better use a faster acting drug, faster acting
Exactly.
mode. Yes.
IV route is definitely going to give very quick
And
response.
PPH is a condition where microseconds matter.
Exactly,
Yeah.
exactly.
Yeah.
And therefore, I said that in case there is no IV line secured, patient has
Yes.
come to some peripheral center
Correct,
from
correct,
some
correct.
village,
Correct,
and they are
correct.
at a dire strait and they want to give, they should give IM.
Then they should, yeah.
Otherwise, most of us will prefer to give it IV.
So I am sure would it be preferred when there is a no scope to give IV or there is inhibition or limitation to give IV.
Right.
Yes. If a patient is not responding adequately with carbetocin, other additional uterotonics,
See, there is no interaction between
yes,
carbetocin and the other uterotonics. So we
you can
can
use all.
safely give them. We can give methylargometrin if not contraindicated. We can give prostodine injection intramuscular if not contraindicated. We can give misoprostol
Yes, yes,
sublingually or per rectally or
correct,
per
correct.
vaginally. So definitely other uterotonic agents can be supplemented. There is no contraindication to using other oxytocics. The only contraindication, like I said, temporary contraindication is using oxytocin because it's not going to act.
Yes, the receptors are
So
blocked.
we should prefer some other group of drug.
Any specific advantage over, I mean, oxytocin to be able to. By the way, madam, how have you seen this side effect of ADH with oxytocin? I
Sorry.
mean, retention of water, fluid, etc. with oxytocin. Have you seen it really actually?
Sometimes in some patients who have received large doses of oxytocin, we
Ah,
do get little drop in the urine output in the post-op period.
mm.
So that is probably,
A rare thing,
high
madam.
doses
Not a
of
yes, yeah,
oxytocin if
yeah.
we have used,
And prolonged
that
periods
can
maybe.
happen. Otherwise,
Yeah.
it's not.
No,
Actually, oxytocin is a pretty safe drug.
correct.
But then like it has its own limitations. So misoprostol also comparatively is I
Safer
would
drug.
say safe to use because number one, it is easily usable by non-trained staff also.
Yes,
All they
that's
need to
important.
be instructed is break the tablet and put it under the patient's tongue.
Done.
So even if they can't put vaginally, rectally, there is no
Yeah,
IV, nothing. Tablet and tablet keeping transferring to centers and keeping it storing
easier.
it is much easier
Operationally, yes.
than drugs.
Correct.
So that is something Misopros definitely scores on
Scores.
that part. Carbopros has excellent action, but very high profile of side effects. Cannot be given in asthmatics, given
Asthmatics, yes.
cannot be given in heart patients.
Yes.
So definitely it has its restriction. Methylargometrin also, we would be careful to give in
Hypertension,
PIH,
yes.
in cardiac disease, in RH negative mothers. If first twin is delivered and second twin is still inside, we would do not want to give it.
Correct.
So methyl ergometrin will have those kind of little
Limitations.
disadvantages. Advantage, of course, is that it's a very good contraction, upper and lower. So sometimes what happens is the bleeding, there is atonia of the upper segment as well as the cervix. Cervix
Oh,
is
oh,
gaping, especially huge baby, twin pregnancies. It's a gaping cervix and general oozing from the cervix. In which case, methadone will give good result because
best.
it help contract the lower segment also.
Enter, yes,
Yeah.
yes, yes. And our time, madam, we had only oxytocin and methargine.
Exactly, exactly. And we were managing with that. Exactly.
And
In fact, now
oxytocin,
misoprostol as a prevention, or you can say as a prophylaxis, I am using in all LSCS patients.
correct, 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 correct.
Irrespective, we still give them carbetocin,
Yes, yes,
but
yes,
we
yes.
put rectally because there is no harm.
Harm,
There is
exactly. And
no
what is
harm.
that?
It is
Yes,
it
yes,
is
yes.
comparatively very safe. There are
Absolutely.
not any much side effects.
And
Just
if you,
putting one tablet in the
correct,
rectum.
correct, correct.
So
Nothing
by the
happens.
time the spinal is given and the baby is out, that action of the meso tablet also comes.
Starts.
And also you are giving carbetocin, which has no interaction. So
And
both the drugs will help give much better outcome. And that
and
we are experiencing
yes, yes.
also.
And PPH, anything we do safer, I mean, faster onset of actions, anytime better.
Sorry, I didn't get that, sir.
No, in PPH, we require a faster onset of action. Whatever we
Yes,
use, yes, finally.
yes.
Should carbetocin be, I mean, you already answered, is a reserve drug. It should not be used as a reserve drug. Should be as a first line.
Yeah, I would say for normal deliveries, who are usually we see normal deliveries now,
Yeah.
100 out of 100, 98 are on oxytocin drip.
Correct.
So those patients, I will not be using Carbetocin as the first drug of choice. And I would definitely want to keep it as a reserve drug.
Reserve drug.
But in case of LSCS, where we
Hmm.
know PPH is, chances are higher, where we know that the oxytocin drip is not there, these patients I am using as a first line.
So wherever the patients are at high risk, we should use it as a first line. Otherwise,
Yes.
reserve is
We
okay.
have other drugs to keep in
Yes,
reserve.
correct,
Like we
correct,
can
correct.
keep prostrodine as a reserve drug.
Correct, correct.
So, there are other methyl ergometrin now actually has become a reserve drug in cesareans because we are preferring Carbetocin. So we need to remember that they are having different set of actions through different mechanisms. So other than Carbetocin and oxytocin interaction, none of the other drugs reacts with Carbetocin.
Isha, yeah,
So can be used as a co-prescription kind of.
How do you compare adverse effects of oxytocin vis-a-vis? I mean, you have already told this, but other than ADH, is there any adverse effect of oxytocin?
To be honest,
No.
I have never seen any side effects of oxytocin. Like I said, some patients get little temporarily reduction in the urine output
Correct.
within 24 hours or so. That is what 24 hours, within 5 to 10 hours, it's gone because oxytocin half-life is very small. That is one big scoring factor. So really speaking, I have not faced any complications of either oxytocin or Carbetocin.
The last question is your one-liner on Carbetocin.
Carbetocin is definitely here to stay. Ease of administration and better efficacy is proven beyond a doubt. Now with the heat stable, version coming out, it will be of immense use in the periphery where there is less resources, less trained personnel. Even in a very low resource setting, any person, like we have mentioned, that can give an intramuscular injection can use Carbetocin. And even prostrodine can be given intramuscular, but the due side effects that prostrodine can cause may not be able to manage in a small resource poor setting, but there is hardly any side effect to Carbetocin. So there is no doubt it is here to stay, and it should be, day by day now the prices are getting reduced. So it will be used as a common drug, even in not only in private, but even in the government sector. That is a huge sector that is dealing with, obstetric patients.
Primary healthcare.
I think primary healthcare should include Carbetocin now.
Madam, thank you so much. It was wonderful. In fact, this is what our doctors want. The doctors who have used it, their experience more than the guidelines and others. Thank you. It was wonderful. It was wonderful.
Thank you so much. Very pleasure talking to you. And thank you to the audience. Thanks to your team, Sachin, Priyanka. They've been relentlessly coordinating with me. And I'm really sorry last time because of some unavoidable circumstances, we had to postpone it. So thank you. It was really a pleasure talking to you.
Thanks all the participants for taking time and attending this. Thank you, marketing team Hitro, for conceptualizing, IT team and field personnel for follow-up. Thanks once again. And
thank you so much.
Thank you, madam. It was a pleasure. Thank you.
Thank you. Thank you. Bye-bye.
Thanks, Sachin. Thanks, Jan.
Thank you, sir.
Yes.
Can we log out now?
Yes, madam.
Yes, ma'am.
Thank you. Thank you.
Jan will log out, huh?